All right, so we're going to get started. It's kind of crazy that we're doing the whole cardiovascular system in just 1 week. So hopefully a lot of the things that we're talking about are things that have relevance to your lives or have meaning for you. If not now, then perhaps later in your life. Right, so last time we talked about the three main different types of blood vessels: arteries that have a really thick, smooth muscle layer and are very resilient and elastic. They need to withstand high pressure and they're customizable. Veins, which have very thin walls, right, so they can be easily compressed for that skeletal muscle pump, and they have valves to prevent backward flow. And then the capillaries, which are the smallest, just a single cell layer thick in their walls, that simple squamous epithelium, which allows for diffusion of oxygen, carbon dioxide, nutrients, and wastes from the bloodstream into the tissues and vice versa. Then we talked about all the different chambers of the heart and the path of the blood flow through the heart, and the cardiac conduction system, that electrical system that synchronizes the beating of the heart and makes sure everything is timed appropriately. So today we're going to talk about these four topics: coronary circulation, heart rate and blood pressure, blood, and blood types. So really quick review of last time so that we're not lost at all. Right, so you remember we talked about how the heart has to pump, it has to contract, and it also has to relax and fill with blood. So like we do in so many things of science, we give those special names. So the contraction of the ventricles is called systole. So I always remember it because it starts with an S, like squeeze. Right, so systole is that ventricular contraction, and then diastole is when it relaxes and fills up. So if you know Dionysus, the Greek god, he kind of chillaxes, so you can remember it that way. So we have systole and we have diastole. Those are the two main jobs. We're going to use our conduction system to coordinate it. So the SA node is often called the pacemaker of the heart, as in the natural pacemaker, because it's going to send that impetus to beat about 70 times per minute. That electrical signal propagates through the walls of the atria, and they kind of go, wah, and they, gently usher the blood down into the ventricles. AV node receives the signal, pauses it for a minute, and then, like lightning, sends it down the AV bundle, left and right bundles, and Purkinje fibers, so that when the ventricles contract, it's a big all-at-once whoomp, so we can generate a lot of pressure and a lot of power. Then we talked about pacemakers, because people asked questions, so I was like, oh, let me find some pictures to show you. Right, so this is an X-ray, and you can see this is the pacemaker, right, that little piece of electronic underneath somebody's skin that you can see here. And the wire from the pacemaker goes through the veins, down the superior vena cava, and into the heart. So here's kind of a diagram of the pacemaker on the other side of the chest, and you can see these wires go down into the heart. Now this person happens to have a pacemaker with two wires, one to the atria and one to the ventricles. Sometimes he'll just have one in the atrium. Pretty amazing, whoever thought to do that, right? We also looked at EKGs, and so let's just look at a couple of fun EKGs, but a quick review. So that P wave is when that electrical signal travels through the atria, and we have atrial contraction. Then we have a pause here while the AV node holds on to it. Then we have this QRS, which is the electrical signal traveling through the ventricles as they contract. And then we have the reset. So this is normal. This is somebody who has a pacemaker. So what we're seeing here is instead of a P wave, there's this little spike. That's the electrical signal from the pacemaker's wire itself, right? And then that's going to move through the heart. Now this person happens to have a diseased heart, which is part of the reason why they have a pacemaker to begin with. So then the waveform that we see, right, this shape looks kind of strange, but that's their ventricular contraction. This again is our normal EKG. I'm just going to show you a couple of other interesting ones. What is going on here, do you think? A panic, it could be a panic attack. It could be, because, yeah, tachycardia or a really fast heart rate, okay? Now, this can be normal when you're exercising. That's part of the normal response to exercise, to increase oxygen and glucose delivery to the muscle cells. That's normal, right? But sometimes it can also be abnormal. Okay, good. What do you think is happening here? This one's bizarre. So this one is, remember when we talked about sometimes the signal gets all wonky and the heart muscle just goes like this and it just kind of quivers? This is ventricular fibrillation, right? This is what we shock people for. Okay, so if you ever see that, my family, they were watching Glee the other night, and it was the episode where Kurt's dad has a heart attack. And so, like, Kurt's dad is laying there in the hospital bed, and on the monitor, he had V-fib. I'm like, no, because he's still alive. But anyway, so EKGs are really interesting. So we're going to talk briefly now about some of the ways that we measure what the heart is doing and what's going on with the cardiovascular system. So clinical measurements, right? Things we use clinically in the clinic in medicine. So the first one is blood pressure. And we literally, when we check blood pressure, we are checking the pressure inside the blood vessels, specifically inside the arteries. And it's going to be different at different moments. So when the ventricles are squeezing, when it's systole, and there's that huge pressure wave moving through the arteries, the pressure is higher. And then during diastole, when the ventricles are relaxed for a moment before the next beat, the pressure is lower. So that's why we have two numbers. So the systolic number is that higher number, the higher number of your blood pressure, and diastolic is the lower number. Right? So that's what we're looking at, the pressure at that moment when the heart is pumping, systole, and that moment when the heart is relaxed, diastole. And we literally are measuring it in millimeters of mercury, which is the same thing that you use to measure tire pressure. Right? Same exact thing, how much pressure is being exerted on the walls of our blood vessels. So normal is less than 120/80. All of you probably have normal blood pressures, unless you drank a lot of alcohol last night. That'll kick it up quite a bit. All right, but it's only Thursday, so I'm hoping you didn't. All right, problems with blood pressure. So if the pressure in the system is too high, we call that hypertension, because remember, hyper means more than. So when we talked about hypertonic, the concentration was higher than or more than the concentration inside the cells. And the problem with that is over time, that causes extra wear and tear on the walls of the arteries. Just like overinflating your tires will cause extra wear and tear on the inside walls of your tires and cause them to wear out faster. Same problem, right? So the arteries can withstand pretty high pressure, but you don't want to push it. So this can lead to damage of the arterial walls over time called atherosclerosis that we're going to talk about more in a few minutes. Your blood pressure could be a little bit too low also, and so the word for that would be hypotension, because hypo means less than. And actually, a lot of athletes and young female-bodied people tend to have relatively low blood pressure. So it's not unusual in the clinic sometimes for us to get a blood pressure on a young person that's 90/60 or 100/65, right? Not uncommon. And that's okay. It's not going to cause you any problems unless that pressure is too low to be able to fight gravity and get the blood up into your brain. Yeah.
So is there like a, I guess, measurement that is typically too low?
Yeah, so how low is too low? And it depends on the person. And it really depends on if you end up having symptoms. So have you ever had it happen where like maybe you get up in the morning and you're running late and you don't have a lot of time and you just quick get in the shower and you take a really hot shower and then all of a sudden like your vision kind of goes gray and you feel dizzy and you maybe have to like hold on to the side of the shower, right? So what's happening in that moment is your blood pressure is too low. Not enough blood is able to fight the force of gravity to get up to your brain. And so your brain is having trouble functioning, right? That's why your vision gets dark. That's why you feel dizzy. And in fact, if your body isn't able to respond quickly enough to increase your blood pressure enough in that situation, what will happen? Yeah, you'll faint, you'll pass out, right? Which is a brilliant strategy on the part of the brain because now you're horizontal and it doesn't have to worry about gravity. Brilliant. Unless you hit that's the problem. You hit the floor or the side of the toilet or something on the way down, you get a big gash on your head, right? But it's better than dying, right? So when people faint, it's because A, their brain isn't working properly because it's not getting enough oxygen and glucose, and B, it's a perfect way to correct the problem, right? Get horizontal, get gravity on your side. So that's why, if you're feeling lightheaded or something, sometimes people will say, well, sit down and put your head between your legs, right? They just want you to get your head down. What's even better is to just lay on the ground and put your legs up in the air, right? Drain all that blood up towards your head. That's even better if you can do it. Okay, so generally hypotension is not a problem, although it can cause some symptoms. So if that tends to happen to you, you might want to eat a little bit more salt and stay really well hydrated. All right, sometimes, however, low blood pressure is because your body systems are failing. If you're critically ill, right? That's a problem. But most of the time in young people, it's just, you're too healthy. All right, pulse, right? So we felt our pulses last time. So you can feel your your common carotid artery is the artery coming up into your neck. And every time your heart beats, your arteries go whoa, 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 as that pressure wave travels through. So you can feel a pulse any place in the human body where an artery is relatively close to the surface of the body. So this is one place. The wrist can be another place. The groin is actually a really good place. Even the top of your foot, you have a little artery that travels on the top of your foot and the inside of your ankle, right? So sometimes if you're just kind of sitting and you can even see it, sometimes the artery going every time your heart beats. So we use the pulse to tell us what the heart rate is, right? So how many beats per minute? That's kind of just the standard of how we measure it. Okay. So normal is usually anywhere between 60 and 90. But if you're an athlete, it might be slower than that. Not uncommon. And caffeine and stress, a little adrenaline, that'll increase your heart rate. A little exercise, that's normal. All right, so blood pressure and pulse. Tell us a lot about what the heart is doing. Questions about those? Yeah. Right. Yeah, so athletes, because their hearts are so strong, their heart doesn't need to beat that many times a minute because it's so effective at pumping the blood out. So their brain actually sends signal to the SA node to slow down. Yeah. Yeah. Yep. It has to do with how aerobically fit you are, how strong the heart is. Absolutely. Yeah. It's pretty cool. Not uncommon for young athletes to have normal resting heart rates in the 50s or sometimes even in the 40s. 45? Yeah. I'm not. Shocker. I know. All right. Okay. Other questions about blood pressure and heart rate? All right. So now we're going to talk about the coronary circulation. So the word coronary just means of the heart. Okay. So the circulation for the heart itself. So these are the blood vessels that are going to bring blood to and from the cardiac muscle tissue. Now you may be like, wait a minute. The heart is full of blood. Why do we need to bring it more blood? And the reason is twofold. One is that the heart muscle itself is pretty thick. In some places, it's like an inch thick. So there's no way we could rely on diffusion of oxygen and glucose from the inside of the heart through all that heart muscle, especially given that our heart muscle is, beating all the time and never gets to take a break. Right? So one is it's too thick. The other is if you think about it, I don't know what's making that noise that they're speaking. It's like Phantom of the Opera. Okay. The other is that the right side of the heart, of course, that's deoxygenated blood. There's no oxygen there for you, right? So we need to have blood vessels that specifically supply the muscle of the heart. So these are the coronary arteries. We have two main ones, a right one and a left one. Very creatively named, I know. okay? We also have veins that are going to take the used up blood from the tissues in the heart and drain them where all of the used up venous blood from the body is going. So which chamber of the heart is that? All my veins drain into the superior and the inferior vena cava, which then dump into the, which side of the heart receives deoxygenated blood? Right or left? The right. And the receiving area of the heart is the atrium, so the right atriums, right? So the veins draining the heart are also going to empty into the right atrium. That blood then goes from right atrium to right ventricle, gets pumped out through the pulmonary trunk to the lungs. Yeah? Is there a difference between cardiac and coronary? No, they mean the same thing. That's annoying. We just sometimes tend to use one word and sometimes tend to use another word. All right, so we have our own blood supply to the heart muscle itself. Here's another image where you can see both the arteries and veins together. I'm not going to make you learn the names of these, but I just wanted you to see this is the front or anterior surface of the heart. There's the aorta. Here's the posterior surface of the heart. Here's where all those veins come together and drain into the right atrium. There's the inferior vena cava and the superior vena cava draining into the right atrium. This is the left atrium, and it's receiving those pulmonary veins from the lungs. That oxygenated blood comes from the lungs through the pulmonary veins into the left atrium, down into the left ventricle, and then the left ventricle pumps it out through the aorta. Okay. So there can be problems. So if you've ever heard, oh, he had a coronary. Well, what they're talking about is a blockage in one of those coronary arteries. These arteries are not that big. They're not that wide. They are smaller than my pen. They're little. So it's not that difficult for them to get some blockages in them. Now, if you get a blockage in a coronary artery, that means you get no fresh blood supply to that entire region of the heart that was supplied by branches from that part of that artery. So those heart cells are no longer getting oxygen, they're no longer getting glucose, they start to get damaged, and they can even die. So this is a heart attack. The fancy word is myocardial infarction. Myocardium is the heart muscle. Infarction is death of that heart muscle. So a heart attack is when part of your heart muscle dies because of lack of blood flow. This is pretty important. Okay. So what causes blockages? Well, I mentioned atherosclerosis earlier. So that's just a weird name. Ugh. Athero means arteries, and sclerosis means hardening. So atherosclerosis is hardening of the arteries. Sometimes it's also referred to as buildup of plaque. You get this stuff stuck on the inside wall of your artery, plaque. It starts out as pretty fatty stuff. So you get some damage to a wall of your artery, and then you start to build up this stuff. And then it just gets more and more and more and starts coating the inside of your blood vessel wall. Over time, you'll lay down calcium in there, and that's what makes it hard. Right? So in our cadaver dissection class, sometimes when we look at the aorta, if you squeeze it, it crunches because there's calcium in that atherosclerosis. And so as this accumulates, it's like stuff gunking up your pipes in your house. And so there's less and less room for the blood to flow through. And then it's really easy for a little blood clot or something to completely block it off. Right? And then you're stuck, and you're not getting any blood flow to that part of the body, in this case, that part of the heart. Here's another example, right? So again, showing an area of dead heart muscle because of a blockage here in the coronary artery. This is what that looks like on a cardiac catheterization. So cardiac meaning of the heart, catheter means a tube. So here's what they do in the hospital. Somebody's coming in with chest pain, they think they're having a heart attack, or they know they're having a heart attack based on their EKG and some blood tests. So they'll take them to the cath lab, and they're going to take a little tube, and they put it in through an artery in the thigh, and they feed it up like a snake all the way up, and they're kind of going backwards into the aorta, and then they put it at the opening to that coronary artery. So this is the tube right here. This is the opening to the coronary artery, and they inject dye that shows up on an x-ray, and they take multiple x-ray pictures as they do this. So what we're looking at here is x-ray dye filling the inside of a coronary artery, but you can see, hopefully pointed out by the arrow, we have a critical narrowing here, right? This is a place where it's almost completely occluded. It's almost completely blocked. Okay, so this is someone who's not getting enough blood supply to their heart muscle. So what's pretty amazing is that nowadays we can do several things to treat that. So sometimes they'll go in and do what's called a stent. They'll actually kind of go in and then and open it up and just smush that stuff on the wall of the arteries out to the side to make room for the blood to come through. Or if they can't do that, they'll do a bypass surgery where they'll open up somebody's chest, usually use a vein, and make a little bypass route to get around the blockage. So that's what a bypass operation is. Again, whoever thought to try that the first time, that took guts, right? But it can work. Yeah.
So is a bypass being shown on an X-ray, or is that just another thing?
Oh, a bypass is not being shown here. This happens to be just a branch off of that artery. Other questions? Are heart attacks hereditary? So heart attacks in and of themselves are probably not hereditary, but the factors that lead to atherosclerosis sure are. Right? So those underlying risk factors. If you have a lot of heart attacks, it can weaken your heart muscle so that your heart cannot pump effectively, and we call that heart failure. So heart failure is the inability of the heart to do its job appropriately, most commonly caused by multiple repeated heart attacks over time, although there are other causes. Right, so this would be a normal chest x-ray. Your heart is not very large. It's about the size of your fist, actually. Sits about right here. Kind of crazy to think about. This person has a very enlarged globular heart, and there's fluid building up in the lungs because the left ventricle just isn't able to pump out the blood that's trying to come toward it. So we just have back pressure throughout the system. So that's what heart failure is. Questions? Yeah, Ben. Good question. So cardiac arrest versus heart attack. So cardiac arrest, an arrest means a stopping. So cardiac arrest is when somebody's heart stops pumping. Oftentimes due to a heart attack, because the heart attack can be so catastrophic that death of heart muscle tissue can be so catastrophic that the heart just stops. Good question. You can have atherosclerosis in other arteries too, right? It's not unique to the coronary circulation. It's not unique to the coronary arteries. So if you get atherosclerosis and blockages of the arteries to your brain, that's what causes a stroke. A stroke is death of brain cells due to lack of blood flow, right? So if they're not getting blood flow, they're not getting oxygen, they're not getting glucose, and they will die. Okay? You can also have atherosclerosis in the penis, and that causes erectile dysfunction in older men. Erectile dysfunction in younger men is caused by other things, right? So anytime you can't get good blood flow into a part of your body, it is going to experience problems. So we want to avoid atherosclerosis, right? We want to keep our arteries nice and clean on the inside. This is a normal aorta as it travels down the body cavity. So they've cut it and opened it up. You can see these holes where branches are coming off. This is one with atherosclerosis. So you can imagine the blood can't flow through there nice and smoothly, right? It's all gunked up on the inside. So we want to avoid that. So the main risk factors for atherosclerosis are Hypertension, high blood pressure, like we talked about earlier, that strain on the inside walls of the arteries predisposes them to those little tears that then set this whole cascade of events in action. So high blood pressure over time increases your risk of atherosclerosis quite significantly. Having high cholesterol, right? So, and hypertension or high blood pressure is often hereditary and can also be due to lifestyle factors like not exercising, not eating right, those types of things. High cholesterol, a lot of what this plaque is actually cholesterol. So if you have extra cholesterol in your blood, a bunch of it's just going to stick to the inside of your arteries. High cholesterol is also often hereditary. It's genetic. It runs in families and can also be due or influenced by the things you eat and how much you exercise or don't. Diabetes is another big one. People who have diabetes have excess blood glucose. Their blood glucose levels are too high. That ends up making their blood vessels kind of brittle and more prone to those little injuries that set this cascade in motion. Finally, tobacco. Smoking for sure, but there's also some good evidence that even chew and dip and other forms of tobacco, smokeless tobacco, may also be about just as bad as smoking because tobacco is directly toxic. There's compounds in tobacco that are directly toxic to the inside of the blood vessel walls. So you might say, okay, well, what about vaping? We don't know. So far, it doesn't look like it's safer, but we don't have a lot of data yet. Mm-hmm.
So for hypertension, you said it's hereditary. Like, how does somebody check, or sorry, not hypertension, high cholesterol? How does one check cholesterol?
So the way we check cholesterol was with a blood test, right? So we actually take some of your blood and go measure how much cholesterol is in it. Yep. You wouldn't know otherwise. Interestingly, blood pressure too, you usually don't feel it if your blood pressure is too high. Like it has to be way too high. Like it has to be like 200 over 100 for people to feel high blood pressure usually. So that's the kind of thing you have to go in and get it measured, right, at a clinic to know.
And the other thing is, Viagra actually originally started as heart medication.
Yes. So the medicine that's in Viagra originally started as a heart medicine, yes. There's lots of interesting, fascinating things in medicine, like Rogaine for male pattern baldness originally started as a blood pressure medicine. And it wasn't working so great for that, but people got hairier and they were like, hey, we could use this for something else. Yeah. So scientific. All right. So these are the big four. So obviously, if you want to prevent the insides of your arteries from looking like this, please don't smoke or use tobacco. It's amazing what a difference that makes in so many ways. Try to eat healthful foods, right? So lots of vegetables, please. Lots of vegetables. Avoid unhealthy fats. And then move your body. So there's a lot of kind of misconception out there that it's all about your body weight. And it's actually not. It's about how fit and strong you are. So the more you move your body and the stronger you are and the more fit you are, the healthier your heart and blood vessels are. Your overall body weight has very little to do with that at all, right? So you don't have to be a certain weight, right? Although I know some people in medicine keep stressing that. But move your body. It makes a huge difference. Finally, if you do get diagnosed with high blood pressure or high cholesterol or diabetes, right, go ahead and treat it, right? So whether that's medications or lifestyle modifications, right, take care of it because over time, right, it's just kind of a ticking time bomb. Questions? Yes. Oh, it's this idea that beet juice helps your arteries. So all kinds of foods, especially vegetables, have really healthful chemicals in them, right? So that's why if you've ever heard like eat a rainbow of food, some of these healthful chemicals, like these phytonutrients they're often called, also cause the different pigments or the different colors in food. So eating a wide variety of vegetables helps you to get all the different nutrients that will keep your body in optimal health. Right? So there's always something about like, oh, this is good for your heart, this is good for your heart, this is good for yes. Vegetables are very good for you. Yes. I don't know that beets are particularly more healthful than, say, red cabbage or something else that might have that same phytonutrient. But they're tasty, especially with goat cheese. All right. Okay, same thing. All right. So now we're going to move on and talk about blood. Oh, I totally missed an opportunity now that it's October to like have some vampires or something up here. So sorry about that. Okay, so we're shifting gears away from the heart and the vessels and talking about the blood specifically itself. And you might remember that blood is a connective tissue, right? It's one of those weird ones, right? Those 4 categories of tissues: epithelium, connective tissue, muscle, and nervous tissue. Blood is a connective tissue. So all connective tissues have 2 features: specialized cells that are in an extracellular matrix. Extracellular matrix just means the stuff around the cells. Okay. So in the case of blood, we actually have several different types of cells. So you might remember loose areolar connective tissue, our specialized cells were fibroblasts, right? Just one. In cartilage, it was chondrocytes. In bone, it was osteocytes. Well, in blood, we have several different types. So our red blood cells, which are the most numerous, all these little, they look pink, right? Those are our red blood cells, which are called erythrocytes. Erythro means red cells, right? Because cyte means cell. We also have white blood cells, which are called leukocytes, because leuko means white in Greek. And that's these guys. There's a whole bunch of different ones. We'll talk about that in more detail in a minute. So the ones that aren't red. And then we have platelets, which are sometimes called thrombocytes, but I'm just going to call them platelets. They're these little teeny things, way smaller than a red blood cell. Little teeny things. The extracellular matrix, then, that these blood cells are suspended within is called plasma, right? So it's a liquid connective tissue because we have a liquid extracellular matrix, and we call that liquid plasma, right? So this connective tissue has plasma with erythrocytes, leukocytes, and thrombocytes inside of it. And so I have my little soda bottle here, and it's filled mostly with water, so let's have that represent plasma. And these beads, most of them are red, they're representing erythrocytes. So usually your blood is circulating and moving. So when you look at blood, it's red. It's only red because of those erythrocytes. And if you let it sit for a period of time, those red blood cells, those erythrocytes, will settle down, and you will be able to see the plasma, right? So the only reason blood is red is because of those erythrocytes or red blood cells in it. Oh, look at that. So if you let it sit, it will separate into 3 layers. Your erythrocytes will sink to the bottom, so this is deep red. Then you're going to have this white layer. This is the leukocytes and the platelets. So now you can see, since this looks white, that's why they got called white blood cells. Even though when we look at them under the microscope, they're stained whatever color because of whatever stained we use, right? They're like, what's this white stuff? It's the white blood cells, the leukocytes. And then here's the plasma up here, if you let it sit. All right. So erythrocytes, their job, their primary function is to carry oxygen. That's what they're all about. In fact, they are so devoted to carrying oxygen that they practically do nothing else, and they are very specially designed to do this one thing very well. So in order to carry oxygen, we don't carry it through our blood as a free gas, right? Because then if I like jumped around, I might get fizzy, right? So we can't have bubbles of gas in our blood. So instead, we're going to tie those oxygen molecules to a protein called hemoglobin. So our erythrocytes, our red blood cells, are going to be entirely filled with this protein called hemoglobin. And hemoglobin holds on to oxygen atoms. Now, in order to make hemoglobin, one of the ingredients for producing that protein is iron. So if you've ever heard of somebody being iron deficient, right, and having trouble with maybe not having enough red blood cells, being anemic, that's what that's called. right? That's because if you don't have enough iron, you can't make enough hemoglobin, so you can't make enough red blood cells, and then you're not good at carrying oxygen to the different parts of your body. So if you don't have enough hemoglobin or you don't have enough erythrocytes, you might get tired pretty easily. Because once you start being more active, your body's tissues need more oxygen because they need to make more ATP in the mitochondria, but you can't because you don't have good oxygen carrying and delivering capacity. You can feel worn out. Going up a flight of stairs can leave you winded, whereas maybe before it didn't. Also, interestingly, people who are anemic tend to feel cold easily. There's lots of reasons why people can feel cold, but anemia is one of them. So red blood cells, or erythrocytes, are so dedicated to just being filled with hemoglobin so that they can deliver oxygen that they don't even have a nucleus. So very soon after they are first formed, they get rid of their nucleus. So like they don't want it to it's taking up way too much room. Right? And they'd rather pack more hemoglobin in so that they can carry more oxygen. So that's really weird because most cells have a nucleus, right? This is the one cell type in our body that does not have a nucleus. Because they don't have a nucleus, they don't have very many organelles at all, actually. They only live about 90 days, which is still pretty long when you think about it for somebody that can't do very much. So our body is constantly making new ones. The other thing that they do, so that they can be as effective at not only carrying oxygen but delivering it as possible, is their shape is what's called a biconcave disc. I forgot to bring my markers. So they have these little dimples, one on each side, right? So it's the same on each side, so that's biconcave because it caves in on each side. That gives them more membrane, more plasma membrane, more surface area, more locations where oxygen can diffuse across. So the whole point of their shape, instead of being a sphere, they wouldn't have as much surface area, right? So they're this biconcave disc. They have more surface area to allow for more opportunities for oxygen to be able to diffuse out into the tissues. They're very dedicated, these red blood cells. All right, questions about these guys? Yeah.
I might have missed this, but like, how are red blood cells formed?
How are they formed? They are made in the bone marrow. So if you've ever, in some cultures it's really common, like when you eat meat or something, to break open the bone and suck the bone marrow out. It's very nutritious, right? That's where you make red blood cells. It's pretty cool. So inside your bones right now, you are making red blood cells, I promise you, at this very moment. All right, let's talk about leukocytes, right? The white blood cells. There's lots of different types. I'm not going to make you learn their different names. I just want you to know there's lots of different types. This is a leukocyte. This is a leukocyte. This is a leukocyte. And these are our immune cells. Okay? So when we talk about immune cells, we are talking about leukocytes. They are one and the same. So this is part of our immune system. These are cells that are part of our immune system. And they're going to help fight invaders like bacteria or viruses. They also sometimes can help fight off cancer cells. And are part of the reason why most of us don't develop cancer at much younger ages than we already do or might. All right, so super duper important, our leukocytes or our white blood cells. Finally, our platelets. So they're technically cell fragments. They're little tiny things. And what they do is if you cut yourself, when you have a cut and it bleeds, the reason it bleeds is because there's an opening in the wall of that blood vessel. Right? There's not blood just in your tissues. It's always inside a blood vessel. It might just be inside a capillary, but it's always inside a blood vessel. So if you're bleeding, a blood vessel is broken or torn or cut. So what the platelets do is they become activated or sticky, and they gum up and form a patch on the break in the wall of the blood vessel. That's what platelets do. And this starts the whole sequence of events that we call clotting. Right? So we're going to patch, it's like putting some spackle on it. right? We're going to pull in the blood vessel so that it stops bleeding. And then over time, we're going to kind of refine that, sand it down, repaint it, do all that kind of stuff. But that initial response, right, they're kind of like the EMTs for blood vessel injury, is the platelets, which are going to get activated, get sticky, and gum this up to kind of plug the breach in the wall. So obviously, if it's a really big cut, right, platelets aren't going to cut it. Oh, that was a terrible pun, right? So if it's a really big cut, platelets aren't going to be enough. That's when you might need stitches or something else to help bring things back together.
So I have a few questions. So like regarding leukocytes and like how this cancer cells, what about leukemia itself?
So leukemia is, so the word itself tells you what it is. Leuc refers to the leukocytes. Emia means lots of it in the blood. So leukemia is often when, because of an abnormality in the production system for white blood cells, you just make a ton, like way too many. And that causes all kinds of problems. Yep.
In regards to platelets, so like what happens when there's like a bruise?
So a bruise is damage to small blood vessels in the tissues, usually because of a crush or an impact injury. So the capillaries kind of pop open because they're thin after all, right? They're not very resilient. Blood leaks out into the tissues where it's not normally present. And then what happens, interestingly, this is a great question. What happens is as your body's normal systems break down those red blood cells then and break down the hemoglobin, it changes colors. And that's what makes it turn like green and all those kinds of colors over time, is you're breaking down that hemoglobin. So anytime you have a bruise, those are blood cells that got out into the tissues because of injury to a blood vessel, usually a small blood vessel.
So there isn't any clotting in that?
Inside the blood vessel, there will be clotting. Yep. All right. So plasma, right, the unsung hero of blood here, right? This is the liquid extracellular matrix. It's mostly water. It's like 90% water. But then there's all this stuff dissolved in it or carried in it. Some of these things are really important, right? Like our electrolytes, like sodium and potassium, calcium, phosphorus, right? Really important because we have to control those concentrations. Nutrients like glucose and amino acids, waste products, clotting factors, so things that we use in addition to platelets to respond to blood vessel injury and prevent us from bleeding to death. It's my brother, when he was a kid, he somehow, like, I think from video games, like, got it in his head that you only had so much blood. And that over time in your life, whenever you would bleed or whatever, you would lose blood. And he thought once you, like, ran out of blood, that was what made you die. So, but no, we're constantly making new blood. But anyway, sorry, that was random. So clotting factors, albumin, which is a really important protein for keeping the osmotic pressure in our blood the same. Which we're not going to get into that because it's kind of more advanced, but it's fascinating. And then finally, antibodies, which I misspelled here. Antibodies, which are special proteins that are made by our leukocytes, that are made by our white blood cells. And they're going to be part of our immune system. So now we're going to talk a little bit about antibodies because they are super cool. Antibodies. They are these Y-shaped proteins. They are made by our leukocytes. They are produced by our immune cells, our leukocytes. And they have these little ends on the arms of their Ys that have a specific shape. And that shape is specific to a particular antigen. Now you might remember an antigen is a protein or other molecule on the surface of a cell that serves like a name tag or an identifier. So depending on the shape, right, so you can see here, this antibody will only fit with this particular antigen. It won't fit with these other ones, okay? But when it fits, it will bind and grab onto that antigen. And then that's going to allow us to either neutralize that invader that has that particular antigen or call the rest of our immune system in to deal with it. Okay. So let's take a look at what that is like. So first of all, it's very confusing with the language, right? Antibody versus antigen. So the way I remember it is the antibody is the protein that my immune cells make to be a bodyguard for me, right? So antibody is the bodyguard. That's what's protecting you from the thing that has that specific antigen on it, okay? So that's how I always keep them separate. All right, so the antibody is the bodyguard. And so what can happen, so here in this diagram, this is meant to be a virus. These little beeblies on the outer surface are antigens. Those particular antigen proteins are what this virus uses to bind to a receptor on a cell. And you might remember receptors are also made of proteins. The whole world is just about proteins, really, and nucleic acids. But anyway, right? But if you make an antibody that attaches to and binds to that particular antigen, then you can basically block all these docking sites. So now this virus can no longer attach to the cell and can no longer infect that cell. And you might remember that viruses aren't technically living things. They don't have any organelles. They can't reproduce themselves. They rely on getting into our cells and using our cells' machinery to make more copies of themselves. They cannot replicate if they cannot get inside our cell. So this is an example. So preventing that virus then by having antibodies bind to all its antigens so it can't dock on the receptor and get into the cell is an example of what's called a neutralizing antibody. Right? We've neutralized the virus. It can no longer get into our cells, therefore it's just going to die and go away. Can't do anything. Yeah.
So some illnesses like chickenpox, you don't get, well, in most cases, you don't get them again.
Right.
But why is it with other viruses like the common cold and COVID, I think with COVID, you can get it again?
Yeah, we're not totally sure on COVID yet. Hasn't been long enough. Right? So yeah, there are some infections that once you're immune, you're pretty much immune for life. You get lasting immunity. So chickenpox is one of those. Mono is one of those. You usually only get it once. Right? And then there are others that you can get multiple times. Strep throat. Right? You can get it again, again, and again. Right? Some antigens our body is really good at making antibodies against. And some antigens our body is just not that good. And that's one of the main reasons why. All right. So in the case of COVID, or the SARS-CoV-2 virus, it happens to have these spike proteins on its outer wall. Those spike proteins are antigens. They serve as identifiers that our bodies can recognize as a foreign invader. They also have a functional role. So you might remember that those spike proteins attach to that ACE2 receptor on our cells, and that's how they get in. So if somebody has antibodies that can bind to that spike protein, then the COVID virus can't get into your cells, and you can't get sick from it. So one of the things that scientists and researchers are looking at right now is if people are making neutralizing antibodies to the spike protein of the COVID virus. Right? And some people do, and some people don't. And this virus is super tricky because the spike protein actually changes shape. It's called chimeric. So it's tricky because you have to be able to get it in the right shape at the right moment. So it's tricky. That's why it's not easy. Right? So when they talk about monoclonal antibody as a treatment for COVID, what they're doing is they're producing antibodies against that spike protein in a lab and then giving them to a patient through an IV. Pretty crazy. All right. So antibodies can do that neutralizing thing where they basically just like surround you and attack stick and attach to all your antigens and make the virus or other cell unable to do its thing. Or they can do two other things. They can activate a chemical immune response, which is shown here. You don't need to know the details. Or they can call in immune cells that will eat the thing, right? So sometimes antibodies act as little flags that say, eat me, right? And then your immune cells just come in, they're like, and they just eat it up, right? So antibodies themselves might neutralize the invader, or they might activate other parts of the immune system to come and deal with it. So if you've heard of that whole like cytokine storm kind of thing that can sometimes happen with COVID that can make people really sick, that's an over-exaggerated response of this chemical immune response. So let's see how we're doing. Pull out your phones. A lot of information.
Okay, so moving on now, we're going to talk about blood types specifically. So when we talk about blood types, what we're really talking about is which antigens, if any, you have on your red blood cells or your erythrocytes. And so which type of antigens you have depends on the genes that you inherited from your parents. So this is genetically determined. It's something you inherit. And there are three different potential types of antigens. Think of them as kind of like accessories or bling that you can stick on your red blood cells. You can have the A antigen. You can have little A's stuck on your red blood cells. They're not really A's, but we call them A antigen. You can have B antigen, or you can have RH antigen. So those are the three different types of bling or antigen or accessory that you can have on the membrane of your erythrocyte. So then the way we name your blood type is subdivided into whether we're talking about A and B antigen or whether we're talking about RH antigen. So there's this category of what's called the ABO group, and it's kind of confusing. So let me show you. So we have a couple of examples of different types of red blood cells here. So first we have this red blood cell that has little A antigens on it. And so we're going to call that type A blood. We have this one next to it with little B antigens on it. And so we'll call that type B blood. Down here, we have one that has both A and B antigens on it. So we'll call that type AB. And then finally, if you have no antigens at all, so this one here has no bling on it, no antigens at all, we're going to call that type O blood. So it can be kind of confusing because there is no O antigen, but there is a type O blood. So the way I remember it is O means no. Okay, so if it's O, that means neither A antigen nor B antigen is present on that person's erythrocytes. So O means no, neither A nor B. So the positive and the negative are ways of describing whether or not the RH antigen is positive. So if somebody has RH, we're going to call them positive, and if they don't have RH, we'll call them negative. So if we look at this first red blood cell here, it has neither A nor B, so it's type O, and it also doesn't have RH, so it's O negative. Right below it, we see another one that has neither A nor B, so that's type no, O, but it has RH, so we call it positive. So here are type A bloods here, so of A and B, they only have A. A negative means that there's no RH. A positive means there is RH. Here are B types. So they have the B antigen out of the A and B. And if it's B negative, there's no RH present. And if it's B positive, there is. And then finally, we have type AB, where they have both A and B antigen. If they don't also have RH, it's AB negative. And if they have all three, then it's AB positive. So why does this even matter? Well, it has to do with how your body and how your immune system regulates itself. And the basic way we regulate our immune system is by looking at a cell, particularly at the antigens on a cell, and saying, is that me? Is that familiar to me? Are those antigens that I have on my very own cells? So in immunology, or the study of the immune system, they call this self versus non-self, right? So you're basically looking at a cell and saying, are you part of me? Are your antigens familiar to me? Or are you a stranger? So if your immune cells see something that's foreign, if they see an antigen that is new and different and not an antigen that it has ever seen before in your body, it's going to assume it's an invader, and it's going to make antibodies against it and kind of unleash the immune system, activate the immune system. So the way this kind of looks is your immune system looks at a cell and says, is this me, right? What antigens are on it, right? And if those antigens are familiar, then we'll say, yes, this is me. And so I'll just chillax. Everything is good. Everything's totally fine. If, however, you look at the antigens and they are unfamiliar, they are not self, right? So no, this isn't me. Then you're going to attack. You're going to activate the immune system to destroy what your body sees as an invader. So let's take a look at how this would work for me. I happen to have A positive blood. So that means my erythrocytes have A antigen and they have RH antigen. So I will only make antibodies against an antigen that I don't have, right? Because both A and RH are self. They're familiar to me. I'm not going to attack. I'm not going to make antibodies against them. But if I see a B antigen, I will definitely attack that. So I will make anti-B antibodies, right? So I have A and I also have RH. My animations are all out of order. Okay, but so I will make antibodies against the B antigen. And we call those anti-B, which is very helpful. All right, so it's really important then that you don't give me a blood transfusion with red blood cells that happen to have a B antigen on them, because that's going to activate my immune system and cause what's called a transfusion reaction. Now, sometimes transfusion reactions are relatively mild, but sometimes they can just be this massive deployment of your immune system that can make you really, really sick, actually. And sometimes it can even be so overwhelming that it's fatal. So back in the day when they were first experimenting with blood transfusions, they didn't know about blood types. They didn't know about these antigens. And so they couldn't figure out for quite some time why sometimes when they did a transfusion, it worked just fine. And other times the patient died, right? So it took them a while to figure that out. Okay. So compatibility, right, is if I have A positive blood, I will only make antibodies against B. So you could give me any type of blood that doesn't have B antigens. And there's a lot of them, right? So you could give me A negative, A positive, O negative, or O positive. None of those have the B antigen. You can't give me any of the types that do have B, right? So that would be B negative, B positive, AB negative, and AB positive. So you'll see charts that look like this, and they're just kind of reminding you of what's present and true for each different kind of type. So here in this first column, these are red blood cells that have the A antigen on them. So these people will make anti-B antibodies, right? Whereas people who have B antigen but not A will make anti-A. If you have both types of antigen on your red blood cells, then everybody's familiar to you. Neither of those is a stranger, and you won't make antibodies against either one. If you are type O, you're kind of a purist. You have no bling, you have no antigens, especially if you're O negative. This one just refers to the ABO groups, but you don't have anything, so everybody's a stranger. So you're going to actually attack both A and B antigens with anti-A and anti-B antibodies. So let's take a look at a different example. So if someone has type AB positive blood, that means they have A antigen, they have B antigen, and they have Rh antigen. So they have every antigen possible. They have all of the bling. So if you give them red blood cells in a transfusion that have these antigens on them, you say, hey, friends, right? Like, I totally know you. Hey, A, hey, B, hey, Rh. Like, you're totally welcome here. So it's not going to fight those cells at all because they have those familiar antigens. So you're not going to make antibodies against any of those antigens because those are self antigens. They're familiar. This means you can give them any blood type. You can give them blood with no antigens on it. You can give them blood with all the antigens on it. It doesn't matter because everybody is familiar to them. They're not going to attack it. So this blood type is often called the universal recipient, meaning it can receive a transfusion from anybody, right? It's universal. It doesn't matter who you give them blood from. So they can receive any blood type and will not have a transfusion reaction. On the flip side, though, because they're erythrocytes, because their red blood cells have all of the antigens on them, you can't give their blood to a whole lot of other people because it has every potential offensive antigen possible, right? So you can only give their blood to somebody else who's already familiar with all three antigens. You can only they can only donate their blood to somebody who is AB positive. Right? So that's AB positive, a universal recipient. Everyone is welcome. O negative blood would be kind of the other side of the story. So these people have no antigens on their red blood cells, neither A nor B nor Rh. So those are all foreign to them, right? They're kind of purists. They don't have any bling. They don't have any accessories. So if you give them a red blood cell that has A or B or Rh or any combination thereof, they're going to be like, I don't know you, right? You're a stranger. And so therefore, I'm going to fight you, right? So if it's a foreign, it's a stranger thing, then your immune system is going to say it must be an invader and I am going to fight. So they'll make antibodies, they'll make anti-A, they'll make anti-B, or they'll make anti-Rh, depending on what they're presented with. They're going to fight it. So because of that, the only type of blood you can safely give them is O negative, right? Because it has no antigens on it. Because they're not cool with any of the antigens. They don't want any of it. They will fight it. So you can only give them O negative blood. Cool, interesting thing about somebody who has O negative blood, though, is that because their erythrocytes have no antigens on them at all, you can give their blood to anyone because there's nothing to offend their immune system. There's no antigens on it. And so so O negative is called the universal donor, meaning that they can donate their blood to anyone. So O negative is the universal donor. This is also why on medical shows on TV and stuff like that, if they're in the emergency room and a car accident victim comes in, they might get, say, give me 2 units of O neg stat, right? So if it's an emergency situation where time is of the essence and you just need to get blood into someone, you know that you can always give them O negative. It doesn't matter what their blood type is, right? So when you don't have the time to test their blood and see what their blood type actually is, you can just go ahead and give them O negative blood while you're waiting for those tests to be run. And you can save their life, right? Sometimes this is a very quick emergency. All right. So in summary, for the blood types, they are named for which antigens you have. If you have A, you have type A. If you have B, you have type B. If you have neither A nor B, you have type O. And if you have both A and B, you have type AB. And then we add a positive or a negative depending on whether you have Rh. So if you have Rh antigen also, then you're positive, and if you don't, you're negative. And then just remember that you're going to make antibodies against anything that you don't have on your own cells. So any antigen that is a stranger is something that you will attack and make antibodies against. So as you work on your lab and your quiz this week, keep that in mind. Sometimes it can be really easy to get turned around and get your head all sideways, figuring out blood types and transfusions and all those types of things. So you will make antibodies against anything that is a stranger to you. So that's the important thing to remember. All right, thanks very much.